Well, welcome to this evening's webinar, Rural and Remote General Practice Research. My name is Associate Professor Jan Radford and I'll be your host for the evening. I'd just like to acknowledge the traditional owners of the land on which we are meeting today and joining us in this webinar. In my case, this is Lutruwita, Tasmania, and I wish to pay my respects to elders past, present and emerging. Just a few housekeeping notes. This webinar is being recorded and you'll receive a copy in the coming weeks. And as you'll see on the screen, you've got a little mark there around the control panel and at the bar at the bottom of the presentation screen where you can set your audios, settings, etc. If you cannot see this control panel on your screen, move your cursor over the bottom of the screen and the panel will appear. It provides you with audio tools for adjustment. It's where you can ask questions via the Q&A module, which will be something we'll use later. So we put everybody on mute to ensure learning will not be disrupted by background noise. And if you need assistance, please use the Q&A feature to raise any technical issues and to submit your questions throughout the presentation. We will be addressing questions throughout and after the presentation in the dedicated question and answer time. You can upvote questions by selecting the tick icon on the question. This will assist in reducing the amount of same or similar questions being submitted. Now I'd like to introduce you to our panel of speakers. We have Professor Claire Heal, and she's the Promotional Chair of General Practice at James Cook University Rural Clinical School based in Mackay. I hope I said that right, Claire, not Mackay. I think it's Mackay. Professor Sarah Larkins is from Health Systems Strengthening in the College of Medicine and Dentistry at James Cook University, just become Dean of her medical school. Professor Andrew Bonney is a GP and Roberta Williams Chair of General Practice in the School of Medicine, University of Wollongong. Professor Lucy Walters is the Director of Adelaide Rural Clinical School. So I'll hand over to Claire now, who will outline the scope of research that can take place in rural and remote settings. Over to you, Claire.
Thank you, Jan, for the introduction. I'll just share my slides. Okay, so I'm going to talk about the scope of rural and remote GP research. And because we were doing this webinar, it made me think about what rural GP research actually is. I'll just acknowledge country. The Yuwabara people are the traditional owners of the land where I am, and pay respects to their elders, past, present and emerging. So the background is that we know that 30% of Australians actually live in rural and remote areas. And the Australians that live rurally have actually poorer health outcomes. So they have a higher burden of disease, they have higher rates of chronic disease, and they have lower rates of, lower life expectancy and higher mortality rates. And there's higher rates of smoking and alcohol misuse and obesity. And also rural Australians are affected to a greater extent by social determinants of health. So there's lower rates of education and employment and income and less access. So it's a perfect storm in that there's less access to health professionals and services in rural areas. Can I just check, are you seeing my Zoom screen as well as my slides? Because I am...
Claire, we are seeing your PowerPoint slides.
Okay, and you're not seeing my Zoom screen? I know, I'm just, yeah, okay, thank you. rural and remote research can be research about specific rural issues, but it also can be research that's facilitated by the fact that you live rurally or that you're in a rural community, or it might be research that's incidental to living rurally as well. I'll just respectfully acknowledge that I'm not including Aboriginal and Torres Strait Islander Australian research as part of this presentation, because I think it's to respect, it's actually a separate area of expertise. So rural research classically is research which improves the delivery of services, be they clinical, public health, prevention, or health promotion. And there's been an awful lot of wonderful research about retention of GPs in rural areas, and how to retain workforce, how to attract medical students and retain medical students in rural areas. It can be research that addresses health determinants, or improves health through other mechanisms. And it can be research that looks at specific rural issues, so things like rural suicide prevention or farming accidents, or obstetric emergencies in rural areas. So it can be about specific rural issues. But also research can be facilitated by the fact that the researcher is living in a rural area where it's not actually about a specific rural condition. So for instance, as an example, the research that I've been involved with for many years is sort of, I suppose, has arrived around a perfect storm of issues in the region in which I live. So we have a very high rate of skin cancer because we have a lot of Celtic background people living close to the equator. And coupled with that, because we're a regional area, we don't have any dermatologists or plastic surgeons. So the GP deal with all the skin cancer and do lots of skin excisions. And coupled with that, it's very hot and humid, and people sort of tend to go fishing and have sort of regional type hobbies. So rates of wound infections are very high. So my own research is sort of centered around the fact that we have high rates of wound infection after skin excisions, and has looked at interventions to improve wound management. So it's not a specific rural issue, but it's really been facilitated by the fact that I'm a rural researcher. And probably other examples are things like otitis externa. So tropical ears almost endemic in North Queensland in December and January, and I've been involved in a trial recruiting patients into interventions for otitis externa, which is actually recruited very well. And rural research can also be research that's actually facilitated by the structure of a rural community. So our esteemed chair, Jan Radford, and I have both been involved in a project looking at familial hypercholesterolemia. And Jan's branch of the project in Launceston has actually, I think, been really overwhelmingly successful because of the structure of a very tight-knit rural community where people don't move, and it's really quite stable. So they've had tremendous success in sort of tracing family histories in her particular cohort of the study. In contrast, my own community is quite transient because of mining, so we've really not had as much success in my particular community. So rural research can be normal research, which is facilitated by living rurally. And also it may be that your particular, as a rural GP, your research interest is independent or incidental to living rurally. And you may in fact want to get involved in a city-based project, which has funding for rural branches of it, because that's your particular research area as well. So rural research doesn't have to be about a specific rural issue necessarily. And then just to finish off with, I just thought about facilitators and barriers to rural and remote GP research. So we know that barriers is less funding. So 1.1% of NHMRC grants actually goes to rural research, and 1.9% goes to general practice research. So rural general practice research is probably a Venn diagram in between there, which is about 0.5% or something like that. So So there's certainly underfunding, and sometimes there's less access to academic mentoring, and Sarah is going to talk a little bit about capacity building as far as research workforce is concerned. There's also lots of facilitators as well. So in rural areas, often there's actually just less competition to conducting research, so fewer people recruiting for fewer projects. Rural patients are often very obliging and really happy to help with projects, so it's often easier to recruit. And there's just lots of interesting sort of topics out there in rural areas. So I sort of think that everybody in their own community probably has their own unique rural medical problem, which is really unique to them and really interesting to research. So I'll just stop sharing now. So thank you, and I'll just pass back to Jan.
Thank you, Claire. That's wonderful. Really nicely sets the scene, the diversity of possible academic practice as a rural researcher. Now, the next person I'd like to introduce you to is Sarah. Sarah is going to talk about her capacity building research, importance of building a local research workforce. And as Claire had said, a very important piece of the puzzle of managing to actually do research in rural areas.
Yeah, thanks very much, Jan, for the introduction. So I'm also I'm coming to you from Walgurukaba and Bindal country, actually up in Townsville, and I've taken the liberty of keeping the NAIDOC background on for another week. I reckon Ash Barty's win gives us a bonus week of using that and celebrating Aboriginal and Torres Strait Islander Australians' contribution to their country. So I'm at James Cook University. I've just this week started as Dean of the College of Medicine and Dentistry, but I'm a GP, a health systems researcher, and pretty passionate about working towards training a health workforce for rural and remote areas. And so what I'm going to talk about today is really what are some of the issues in rural health research very quickly, and then moving on to some solutions that we've been involved with. So talking about the JCU cohort program and the Spinifex network. So if you could share my slide, please, Melissa. So what we really know, obviously, that the rural pipeline works very well in terms of training a fit for practice workforce, so selecting students from rural areas and training them in rural and regional areas, and providing postgraduate training opportunities also in rural areas. We also know that there's insufficient investment in rural research, and Claire talked a little bit about that. Leslie Barclay and David Lyle have written about that. So not only is the actual funding that goes to rural practice, to rural research insufficient, also the rural representation on the bodies that make the decision about where research funding goes is sorely lacking. So for example, all the major bodies of the NHMRC, the MRFF missions, their advisory boards, 59 out of 60 of the people on those are large city metropolitan. So, severe underrepresentation there. We know that there's a shortage of clinician researchers beyond capital cities to do all this rural research that we need to do. So, for example, where I'm based in Townsville, 10 years ago, there were fewer than 5 clinicians with a PhD at Townsville Hospital, which is the largest referral hospital in Northern Australia. We also know that research done by rural and remote clinician researchers tends to be very grounded and strongly translational. As Claire said, it responds to problems that are experienced by people in those areas. And as a result, it often comes up with solutions out of necessity that are very applicable to Australians in other regions and could be applied in more metropolitan areas. So if you put all those facts together, there's really a need for good training in place options. So how do we provide that training, provide that capacity strengthening so that rural clinicians are able to engage in this research that's sorely needed and can work together to generate service provision, teaching and research hubs of activity that may in turn help with workforce retention. So we need to think about how to support and network the health workforce, how to activate them, turn them on, that they could be part of the solution in solving these problems through doing applied translational research. And the training options need to be flexible, they need to be part-time, and they need to involve support, remote support. And through this, we can help them learn how best to apply evidence-based best practice in these very challenging and diverse geographies where they're working. So I'll talk a little bit about the JCU cohort doctoral program. So that's what this diagram represents. This is a program that we've been running at JCU for 10 years, since 2011. It started with an intake of 13 health professionals and has taken in around 13 to 15 health professionals every 6 months into cohorts, and now has 135 scholars enrolled in it. And they're mostly health professionals. They're from all over the place, actually. So some of them are from the Pacific, they're from all over rural and remote Australia, including Arnhem Land, all over the place. And they're mostly engaging in their clinical work full-time whilst completing research studies, so either a pathway project, a grad cert, or else a PhD on a part-time basis. And we run it by providing a lot of support virtually, and then twice yearly on-campus blocks in Townsville, where they fly in and mix with the other members of their cohort and receive some very intensive block training and tick off a lot of the compulsory components of their candidature as well. There's a lot of networking, a lot of support, in addition to all the normal advisory panel support that's provided. And it's been very, very successful in terms of delivering outcomes with 65 PhD graduates, many of them rural and remote health professionals, and large numbers of publications, very timely completions given the way that people are doing it. So I'm probably running a bit short of time. The last thing I want to talk about is the Spinifex network. And this is a community of practice, an organisation, if you like, that's convened by the 3 Centres for Innovation in Regional Health. So it's New South Wales Regional Health Partners, the Central Australian Health Science Network, and Tropical Australian Academic Health Centre, which I'm heavily involved with. And it's a network that aims to mobilise the national rural health and medical research to really strengthen rural health. And it has about 60 member organisations, been going for a few years now, and really tries to advocate and embed rural and remote health research priorities into the national research agenda, address some of those problems I talked about early on, to work together to build capacity for rural clinicians in research and rural health services in evaluation, and developing a place-based model of research training to support skills relevant to their own clinical practice. So that may involve some adaptation of this kind of a model. It may involve other possible models. And identify a pipeline of rural and remote clinicians who are interested in research and research training, and try and enrol them in tailored mentoring and research. So there's a couple of activities that are going on. It's an ongoing piece of work. In our experience, it works well in terms of building links between the clinical and academic community and allowing people to develop skills in research whilst training in place. Thank you.
Thank you very much, Sarah. That was really, really interesting, actually, and hopefully inspires the people who might be our audience to consider the different ways that there may be to obtain skills in research and etc. Gives me lots of great ideas. Now I'd like to introduce Andrew Bonney. So I'll hand over to you, Andrew. You're going to talk about your regional practice-based research network, and we've worked together on a different project at least one project, hopefully more, where we both use that network for research.
Great, thanks very much, Jan. I think there might be a slide coming up. So I'm Andrew Bonney. I'm down on the south coast of New South Wales. So we've gone from one side of Australia to the other. And that's on Thurrowild land, down just a little bit south of Jervis Bay. That's where I live. And this is just a rough distribution of some of the practices in ISPRIN. So ISPRIN is a practice-based research network, and I want to talk a little bit about practice-based research networks in my little time slot. We've got about 90 general practices in ISPRIN now, spread over mostly rural and regional New South Wales. We have got practice down in Victoria, another one down in Tasmania, mostly in New South Wales, and located in and around the Illawarra region, or directly in the sort of western slopes of New South Wales over the Great Dividing Range. And ISPRIN's been running for about 10 years now, and the reason for starting ISPRIN really was because research is fun, and I wanted to be able to get some of my friends and colleagues involved in the fun of doing research, because it really is a highly enjoyable exercise. Just the idea of generating a nice practice-based problem that you want to try to get an answer for, particularly very pragmatic problems in general practice, getting some of your colleagues involved in the exercise, collecting the data, analysing it, and then hopefully publishing, is just a really satisfying exercise. But the problem is, of course, that in amongst the satisfying bits, there's also some really not satisfying bits, which include things like managing budgets and hiring research assistants and getting ethics applications through, and various HR bits and pieces, ethics reviews, and then in and around design, you might have an excellent research question, but if you're not familiar with research methods, then trying to sort out how to answer might be difficult. So sort of methodological side of things, and then ultimately analysing the data and writing it up. There's a fair bit of the research exercise which is not fun to the average GP, who's very pragmatic, likes to solve problems, likes to help people, and doesn't want to spend a lot of time messing around with bits of paper or spreadsheets. So the idea of ISPRIN has been to create a very strong peer group with some firm research support backing it behind it. And whilst the backing behind it kind of expands and contracts according to whatever the project is and the amount of funding that we've got at any particular time, as much as possible, what we try to do is incorporate GP-led ideas into a research project and then provide some support around it so that the project is successful and can be effectively analysed and hopefully published. We've been reasonably successful with that. Over the years, the strike rate's pretty good. It's probably in excess of 80%, I think, of projects from inception to publication. We've had well over 20, maybe 30 projects, and probably around $4 million worth of research funding. We tend to group the projects into two separate kinds of projects. That's what we call bottom-up projects, which are usually member-driven or member-led. Frequently, they're ones that have a very pragmatic question that GP members come up with. We've been able to find some funding or support. We've been able to find some other practices interested in the network in supporting with recruitment, and been able to provide some analysis and publication support around that. And they're typically the ones that are the most fun. We also have what we call top-down projects, which is where if we've been successful in getting some competitive funding for a suitable project, then we invite member practices to be involved. And we try and make sure that there's some financial support for the practices for that involvement. And where appropriate, if possible, keep the practices involved in the research process if we can. Jan's just mentioned a recent RACGP funded project called Equip GP, which included our research network and also one in Jan's neck of the woods and also one in Victoria. Those projects are often sort of fairly top heavy and perhaps not quite so much fun, because the fun ones really seem to be in and around what the GPs themselves want to find out about. Along the way, practices learn some research skills, some research methodology. We typically like to keep practices involved throughout a project. So every 6 weeks or so during a project, we would have all the member practices join us on a teleconference or nowadays it's going to be a video conference. And we like to involve practice managers, practice nurses, GPs, people who are actually going to have their sleeves rolled up and involved in the project as part of those meetings. It improves the project significantly, both the application of the project within the research itself, but also then the implementation of the findings. So if the practice is very involved in the undertaking of the project, then we have a good understanding of the implementation of whatever that particular intervention has been for the project, and it helps with implementation significantly. And we often would construct an implementation piece into the research so that there's a section there where we can go back to practices and try to understand who worked for what, when and how, and incorporate that into the findings at the same time. We also like to try to give back to the practices the research findings which are applicable for them. So we would typically have something like a poster or a brochure which would outline the major findings of the research, which the practice can then have, and they can have those perhaps in their brochure tray for patients in the waiting room, or a poster that they can put up on the wall. That way the patients also can see the results of the projects that they've been involved in. So we found it really useful. It's challenging and reasonably work intensive, and it also requires money. So the activity goes up and down depending on what we've got funding for at any given time. But certainly along the way, we've had a lot of fun. And I would certainly encourage questions about that later on in the session. So I'll hand back to Jan unless Jan's got any other questions she'd like to raise right now.
Thank you, Andrew. That's lovely. So I like the idea that you brought the concept of fun into it, that all of the maybe the other less fun bits are sort of done by the academic team, which of course Sarah is training up for us. So, you know, it's all sort of falling together, this webinar. Now I'm going to introduce Lucy. Lucy Walters is based in Mount Gambier. We bring, I hope I get my geography right, South Australia into the webinar, and Lucy's researched in a lot of different areas. So I'll leave her to tell you about that, and another piece of the rural and remote research puzzle will be described.
Hi everybody, and thank you very much, Jan, for introducing me. Firstly, I'd just like to acknowledge the Boandik people on whose land in Mount Gambier I am in today, and recognise elders past and present. Now, I think I've got a slide as well that if you can share for me, Melissa, would be lovely. I thought I might tell you a story and take this on slightly different track. I left med school and then GP training, and was very convinced that if I knew one thing for sure, it was that I was not going to be an academic when I grew up. A, because I thought they were much smarter than me, and B, because I couldn't imagine research as being interesting. And yet here I am today with a very different path. Now, how I got first involved in research is that I had an epidural headache after a procedure, and my boss at the time, Professor Paul Worley, who you'll all know as the first Rural Health Commissioner for Australia, was very nice, and over the ensuing 3 days while I was lying flat, he would ring me each morning and we would have a lovely chat about things like GP teaching in general practice, and he would say things like, oh, but GPs don't want to teach medical students because it'd take too much time. And I'd get quite frustrated at him and say, of course it doesn't take more time. There's lots of ways to make it efficient and it can't take more time. And he'd finish the conversation by saying, oh, really? How would you prove that? And put down the phone. And of course, I would spend the day stewing over that and would respond the next day by saying, I could put a video camera in the GP's room and we could videotape medicals or the GPs one day when they had a student and one day without. And then I'd be able to measure the length of time of each of those consultations. And, I'd be able to prove to you that it doesn't take longer to have a medical student with you. And he went, oh, what would be the ethical issues with that study? And he'd put down the phone and I would stew over that for the day and then say, well, if I was going to get ethical approval for that, I'd need to demonstrate that I had a number of practices that were interested, and I'd need to consent the patients, and I'd need to make sure that we secured the way that we stored those videos, and I'd be able to do this and that. And he'd finish the sentence, the conversation with another question. And by the end of the week, I was enrolled in a PhD. Now, it's a reasonably dramatic story on how I was cajoled into research, but you can see that what was really happening is that I was interested in a question and that I was seeking ways to answer that question. Now, I don't suggest that all of you need to have an epidural headache and lie flat on your back for 3 days in order to become interested in research. And we certainly know that many general practitioners are interested in research, but anxious that they may not have the skills and the tools in order to make a transition from seeing patients to, writing research papers. So I'm here to reassure you. There is a language that you need to learn when you undertake research, but actually if you peel that language away, the important part of being a good general practitioner is curiosity in our patients, taking histories, and then being able to fit the stories that we hear from our patients into known patterns of diagnoses. So, a heavy feeling on our chest becomes crushing central chest pain, with a risk of a myocardial infarction or cardiac event. So the same process happens in qualitative research, where we take information, often interviews from people that are important and informed in the experience that we're interested in. And then we look for the patterns that are found in all of the interviews through qualitative data analysis to make meaning of all of the interviews. So some of the research that I did for my PhD looked at how GPs experience the process of supervising medical students. Other examples of qualitative research that I've been involved in as a GP registrar of mine looked at what patients' experiences were as they commenced or made a decision to commence using a dose administration aid. One of my favourite recent studies has been looking at clinical courage. So we asked rural GPs to explain how they experienced when they had to stretch themselves outside their comfort zone in order to provide the care that their patient required. So they are just like taking a history and meaning making from our patient history. They are collecting information through taking questions and then looking for the consistent stories that help to make meaning. I think general practitioners, a friend of mine describes us as being dirt demographers. So if we get a number of people that present with a collection of symptoms, we start to recognise that a probability of a diagnosis is increased. Our experience pre-COVID, thankfully, was that of a common cold or flu, but certainly we're all now very attuned to the risk of COVID and seeking out examples of where or times when that becomes more frequent in our communities. So dirt demography is what we do as GPs when we recognise patterns of illness that are occurring within our own communities. We do that mostly by collecting data, the number of the different patient presentations that come in over the course of a day or a week or a month or within our practice, and then analysing that to look for patterns. And so quantitative research can help us in general practice. We have all of the information that's available in our patient notes. So we have information that's already collected for us, or as Andrew pointed out, it might be information in a much broader group like of practices, or in data groups like the MBS billings or the PBS prescribing material that we can then look for trends over time. Or we can collect our own data. We can look at, whether particular events are occurring more frequently in our patients. So, for example, as Jan and Andrew described, the information around hyperlipidemia and seeing whether there's particular types of hyperlipidemia that can occur within a community. The other important research that we can do, particularly in rural areas where we have a very embedded role within our community, is that we can do that action research where we find a problem that's presented by the community. It might be youth suicide or challenges with anxiety associated with COVID. We can put together some actions that are provided either with a clinic-based intervention or a community-based intervention, and then measure the outcomes over time. The most impressive example of this that I saw very early in my general practice career is when a group of GPs in the Limestone Coast region decided that they wanted to motivate people to use their seatbelts in their cars more often. And they, with the police and a community group, invented the black and red posts that you can see on the side of the road in South Australia that indicate where somebody has had a car accident and either been injured or died. And over a 7-year period in the late 80s, the deaths and injuries in car accidents in South Australia, in the Limestone Coast, reduced by 30%, while they increased by 7% nationally. And it was about changing the way that people were reminded about seatbelts. So I hope that this very brief presentation has given you some thoughts about the fact that you already have some qualitative research and quantitative or pattern recognition research skills, which will need formalising, and you will learn a new language if you choose to take the opportunity to research, but can very much enrich your role as a general practitioner. Thanks, everyone.
Lucy, that was marvellous to dive into some of the techniques that are used and put them in the context of everyday practice, really. So that was really fantastic. So we've seen a wonderful introduction by Claire covering the vast area and the sorts of topics, and then skills building in a research workforce from Sarah. Andrew, the practice-based research network, which goes right out into the communities, often that have our medical students. That's been my experience. I build my practice-based research network from practices that take my students, and then coming to Lucy and some of those skills, which in fact we've got. Then they need a bit of formalising and polishing and guiding and mentoring. But anyway, we've got perhaps I can see a chat here. What's the chat say? Oh, okay. Everybody back on screen and off mute, please. So, Claire, if you could join us too, that'd be great. And so I would really invite everybody who's guests, if you would like to put a question in the Q&A box. We would love to hear your questions, and no question is a silly question. And we've got a team of experts here who could answer those questions, reflect on them. So whilst we're waiting for some of those questions, I would like to just sort of ask of my colleagues how you've grown your practice-based research networks. I was inspired by Andrew. I went off to a primary care conference in Canberra, and I thought, oh, he's describing in research words what I have with my medical students. We have a close connection with all of our practices, and so we had our students actually doing audits within the practice, so dipping into all of that data that's sitting there in our electronic records. And then we had the students presenting those pictures that they found, those patterns, back to the practice, and finding out why the pattern of data looked as it does, which was quite good for the students, because they then saw that you don't blindly apply a clinical guideline. You in fact implement with wisdom, as you should, and your community has a particular need. So it was a good learning experience for students to do that. So that, and then it sort of became a bit more of a research network after that. But anyway, I waffle on. Sarah, have you got a practice-based research network that you use?
Well, so yeah, Claire and I have both been involved in one from like years ago, 15 years ago, the North Queensland Practice-Based Research Network, and lately the parts around Mackay have been the most active. It's had various phases of activity at different times, but very principles in terms of GP-led research based on small research ideas from general practice. Practice nurses doing the bulk of the data collection, and often the practices where we have students as well. Yeah, and I'll hand over to Claire, because Claire's been leading the. It was spread across Townsville, Cairns, and Mackay, and the most active part of it right at the moment is Mackay.
Yeah, look, we're very productive, but just quiet in our advertising, I think. So we did have funding in that. I think the minimum you need for a functional practice-based research network is, I think, a half-time research assistant and a website. And unfortunately, we haven't had a great deal of funding recently, although we're hoping to have a renaissance. So we'll see. Yeah, but we're still very active medical students. There's always at least one or two projects going. Often now it's medical student driven or GP registrar driven projects. But yeah, it's still ongoing and we are still quite productive. So yeah.
And as TARC takes off, our academic health centre, it's very definitely a priority to develop that further. And also the teletrials, the National Teletrials Initiative has money of that would be successful in getting together with Queensland Health, a fair bit of money for primary care trial development. So that'll be very helpful too.
Yes, I think I may be part of that as well. So it'll be a really nice knitting together of a heap of practice-based research networks. We've got a couple of questions on the Q&A here. Lucy has just been fabulous in telling us how she got sucked in by Paul Furley, a PhD. But Heather's wanting to know, Sarah, Claire, Andrew and myself, the path to rural GP research. So Andrew, can I ask you first how you started? What was obviously epidural life, the headache?
Yeah. Look, it's interesting, isn't it? How it can just be a single moment. I had, unfortunately, my practice is in a small town, about 3,500 people. People get very attached to you. And I had a diabetic patient, who unfortunately developed an acute kidney injury over a weekend and didn't seek any help because he was waiting till I was back in the office. I wasn't on call that weekend, and he sadly passed away. It was one of those times when continuity of care wasn't the thing that was needed. He needed to see somebody else. It troubled me and I was particularly interested because one of my registrars was on call that weekend, and the patient didn't want to see the registrar and wanted to wait to see me. So I had this question about, well, what do patients think about registrars and how can we encourage patients to see registrars? And I had just finished a master's, more for intellectual curiosity than anything, and thought, oh, I'll get a little bit of money from the GP, the original training provider at the time, just to do some qualitative work. And you know how these things happen, Lucy, you kind of described one thing. The next thing you know, you're doing a PhD. Oh, how did that happen? How did that happen? But anyway, look, it was a lot of fun. And probably that then was the kernel of the practice-based research network, because the RTP was reasonably close-knit as a sort of regional training provider. I lent on lots of my buddies for data collection and around what I wanted to do there. And so it didn't come as a surprise to them when I sort of suggested we started a practice-based research network, because they knew that I was already not quite right anyway. And so they weren't surprised by that particular suggestion. So that's how I got into research.
So
it was around a specific...
Lucy was about a sort of an educational issue, really. And with you, it's the same sort of thing, vocational training, and with Lucy, the undergraduates. So that's fascinating. Sarah, what about you?
Yeah, look, I mean, I did my undergraduate stuff in Melbourne and took a year out and did a research degree, a Bachelor of Medical Science. And it was about as far as from what I do now is possible to imagine. It was in a paediatric surgery, BMed Sci, in the role of the gubernaculum in testicular descent. So it was lab-based, torturing baby mice and doing immunofluorescence staining and you know, all that sort of stuff. So I learned a bit about research, but nothing about what what I'm interested in now. And then after completing, I did my junior doctor years in Melbourne too, and just headed up to here with the hospital system and thought, bugger it, I want to be a generalist, a GP, or I want to do, and the other formative thing was I'd done a elective in year 6 on the Pitjantjatjara lands in a little tiny community called Amata. And that was, you know, one of those just life-changing times from a medical school, but with zero content on Indigenous health at that time. So I decided I couldn't do anything else really apart from Indigenous health clinical work. And so moved up to North Queensland and got into research for a few reasons up there. So number one, there was just a whole lot of clinical needs that we needed the answer, that we immediately needed the answer for, and we needed to find out how to improve things and make things work better. And we're being asked by our clients in the Aboriginal Medical Service to work with them to do that. So started doing small projects and built from that. And anyone that's worked in the community-controlled health sector knows that you need a very wide range of public health and research and improvement skills, as well as the clinical skills to do that work. And the other the other part was also sort of time of life stuff. So, you know, I was at that stage of life where you're doing GP registrar training. I was doing a Masters of Public Health. I was having 3 small children, you know, and on teaching, teaching into what was then the North Queensland Clinical School of UQ before JCU started its medical program. And at that stage, you know, when there's a whole lot of little bits and pieces going on, full-time clinical work is actually very difficult to manage. But a bit of this and a bit of that and a bit of research actually fits really well in terms of flexible hours and being able to do things. So, and I guess from there, I just got a bit of a passion for it and met other researchers and started doing more and more. And then,
Did you do your formal training then in that sort of biomedical sense? You sort of got formally trained there, whereas your PhD, was that later?
No, my PhD was in North Queensland while working in community controlled health and Indigenous health, sort of public health topic related with the topic coming straight from my patients in primary.
Amazing. You're so busy. The time of life you're busy, you may as well be very busy. And Claire.
Do you mind? I'll just quickly tell my story. So a bit like Lucy, I never meant to be a researcher. I didn't think I was clever enough and I was a terrible medical student. But I started doing a bit of teaching for JCU when the Rural Clinical School opened in Mackay. And I think Richard Hayes, who was the dean, sort of said, "Oh, how's your research going, Claire?" And I was like, "Oh, am I supposed to do some research?" So, but we had an evidence-based medicine group and 2 of the GPs driving from a rural practice to the group had an argument about whether patients could wet their sutures after they had skin excisions. And one of the GPs was adamant that it was much better for them to have an early shower. And the other one was like, no, they have to keep it dry for 48 hours. So they actually initiated this project. And I thought, oh, well, I better sort of, I better facilitate it because I'm supposed to be the academic here. I was sort of doing a 0.2 job for JCU. And we just recruited loads and loads of patients into this project because everybody wanted to do it. It wasn't my idea or JCU's idea, it was their idea and the project belonged to them. So we recruited all these patients and then I wrote it up and we submitted it and the GPs wanted to submit it to BMJ and I was like, oh, well, I don't think it's good enough, but we can have a go. And then it was accepted and actually published as the leading article on the front page. So, and then I just got sucked in basically. So early success and I couldn't sort of stop doing it. So, but yeah, it was just a very practical grassroots sort of research idea.
And change practice so well.
Yeah. And since then, look, we've done five very similar trials in Mackay and actually a couple in Townsville as well. So it's just sort of kept going. Yeah. And there's that ongoing in Townsville at the moment. So yeah.
The big hi to Heather who asked the question. Come back to North Queensland anytime you want, Heather. Heather, we'll always find a job for you.
It is. That's a piece of legendary GP research, by the way. I was in awe of Claire, that particular paper, just how good that was. That the GPs drove it, and it was a lovely randomised control trial. And yeah, it was, and the follow-up ones have been terrific too. So yeah, I have been in awe of that. Well
Dan,
done.
if I can also add, I think one of the things that I've loved about research, and I do think, we're incredibly you're incredibly fortunate if the stars align and give you the time to focus on a PhD. It means that you're likely to have all sorts of things like family and income and things sorted enough that you can make that time for yourself, because it's a very self-orientated time. But it was really helpful for me when I was similar to Sarah, juggling children and clinical practice, because those things are very emotionally draining. You really want to give to your kids, you really want to give to each patient that comes into the door, and they're also quite sort of demanding in terms of, you need to do this now. There's a patient in your room and you need to manage whatever is their needs are right now. Your child's hungry and needs tea right now, and you need to manage that. And so what a PhD did was allow me to have a small time, in each day or week or however, because it varied a bit depending on the time of the PhD, how I organised my time, that was completely about taking the time to really cogitate and really understand something deeply.
Yeah.
And that's such a different way of being. So it was soul food for me.
No, it is a very different activity, but it can be at different phases. Look, there are a couple of more questions here. So Martin is asking about practice-based research networks being in local universities. And I've not heard of a practice-based research network. Hang on, I'm going to retract that. I'm just thinking of the recent work that the regional training organisations have pulled together. So that's not necessarily a university affiliated, or maybe it is. I'm just thinking of Parker McGinn, but generally it's the local university is where you're going to find them, and they'll take you in. So it's so anonymous attendee. I'd say contact your local rural academic and see if they've got a practice-based research network.
And Jan, the RACGP finally has a research research website page, which has links to every practice-based research network.
I didn't know that. That must be very recent.
Yes, it was. I found out yesterday. So yes,
Brilliant.
So it's live. I can't give you the link, unfortunately, but someone else.
No, it'll be good to add to maybe at the end with when we do the webinar recording, perhaps we could somewhere put that in. That'd be great. And then somebody, Odanio Johnson, Lakaya, I probably mangled your name, I do apologise, but is asking, Claire, is there any route for a GP to get into clinical PhD program at your institution, which is JCU, which I suppose is Sarah's institution as well? So, yeah.
I think that might be better answered by Sarah with the cohort program.
Yeah, sure. I just put the link to the cohort program webpage chat in response to that question. And so certainly, I mean, there are all the eligibility criteria, but there are pathway programs too. And that was one of the things that I didn't say that, I think it's also really important is sort of starting out programs for people that haven't necessarily done any research before and don't have the prerequisites yet for a PhD. And I think there's a lot of people, a lot of clinicians that can do really good research that don't necessarily need to go on and do PhDs. So some do, and that's great. Really encourage it, but you can also really get involved and dip a toe in the water without the commitment that is that. So the link has some people you can talk to or contact either Claire or myself, and we can talk a bit more. But there are eligibility assessments, but the cohort would be the way to go.
That's wonderful. Absolutely wonderful. I'm afraid that's all time we've got for this evening, but thank you everyone for coming along. And we hope that our audience enjoyed the webinar. I've very much enjoyed hearing from all my colleagues who, in fact, you just get another side to a person who you've known for a while. Look, thank you very much for sharing your knowledge. I'm just going to mention 2 other webinars in the series that are coming up. On Thursday, the 12th of August, we'll hold Making Better Use of Your Medical Records for Decisions, Care and Quality Improvement with Professor Ting Lau, Dr. Rob Hosking and Professor Parker McGinn. And that's a webinar in a collaboration between the RACGP Expert Committee Research and the Expert Committee on Practice Technology and Management. So that'll be our next one. And then I'll be organising one which is quality improvement for clinicians. A lot of the research that I've done, really, if you look at it, it's sort of going through your data in your practice and benchmarking it against best practice. It might be to find your patients with familial hypercholesterolemia and manage them better, or any other activities. Done a lot of work with kidney disease and atrial fibrillation, etc. So quality improvement for clinicians will be the last in the series on the 16th of September. But that's it, folks, really. So the events team will be in touch with you, I assume our attendees, and you'll be able to access the webinar as an on-demand activity, and look out for the other webinars that are coming up. But thank you so much, Lucy and Andrew and Sarah and Claire. It's just been brilliant. I really enjoyed it.
Thanks, everyone. It's been really nice to be part of this.